Harrison series. So today we're going to spend around 30 minutes trying to learn about a very crucial topic. The topic is crucial because day in and day out, we keep losing patients in the hospital to this entity called as sepsis. So today we will understand what is this sepsis, the concept, and the basic steps that we need to take to manage a case of sepsis. Now, sepsis is an extremely vast topic. I would call it as a specialist topic, which is to be studied by the internal medicine, emergency medicine, and critical care specialists and anesthetists and surgeons alike. I will focus on what an undergraduate student, an MBBS student needs to know from this topic. Otherwise, this discussion will go on for hours together. Lot of recent research and evidence, all of that cannot be covered, or it's not required for an UG student. We will focus on what is required for you so that you can write a 10-mark answer on this question, and anything that can be asked in NEET PG will be covered, right? So what is sepsis? Can anybody tell me what do you think sepsis stands for? What is sepsis actually? What is sepsis? Whenever I ask students what is sepsis, they will say infection of the blood. Infection of blood, or having the microorganisms, the bacteria or fungi or viri inside the blood, does not mean sepsis. We use term called septicemia for that. Septicemia means you have circulating organisms in the blood. Means the infection is not restricted to a tissue, but the bacteria or fungi or viri have reached the blood and they are circulating. That is septicemia. Septicemia is not equal to sepsis. And in fact, septicemia can be precisely subdivided as saying bacteremia when there are bacteria present in blood, or you can say viremia when there are viri present in blood, or fungemia when fungi are present in blood. That's not sepsis. Then what is sepsis? Absolutely right, Reddy. Sepsis is a form of multi-organ dysfunction which is arising out of infection. So let us define sepsis now. What is sepsis? Sepsis stands for life-threatening organ dysfunction. Life-threatening organ dysfunction. Organ dysfunction. So your organs like kidney, liver, brain, lungs, these fail or become dysfunctional to the point that it can put the patient's life at threat. And why is this happening? If you're thinking it is because of infection, bacteria came and caused the damage to kidney, or bacteria came and caused the damage to the brain or the liver or the heart, we are wrong. It's not the bacteria or fungi or viri which are causing the organ dysfunction. They are infecting the body for sure, but it is your own immune system which is causing the organ dysfunction. So sepsis is defined as life-threatening organ dysfunction due to dysregulated host response. Means your body's immune response is not regulated well. Dysregulated host response to infection. This is the basic definition of sepsis. Life-threatening organ dysfunction due to dysregulated host response to infection. So basically what happens is, when you have an infection, body produces inflammatory cytokines, pro-inflammatory cytokines, for example, interleukin 1, interleukin 6. These inflammatory cytokines, their levels in the blood increase and they go to different organs and they cause damage or inflammation of those organs. That is how we are losing the function of organs. The bacteria do not directly, they are not causing the organ dysfunction. Clear? Okay. Now this is the conceptual definition. Now how do I diagnose it? What is the criteria to say that this patient who has infection has sepsis? So if there is infection plus organ dysfunction, you can call it as sepsis, right? Okay, now I know if there is infection, there are clinical symptoms related to it, right? So either confirmed or suspected infection. But how do I quantify the organ dysfunction? Whether this infection has resulted in organ dysfunction, how will I get to know? The diagnostic criteria for this sepsis is confirmed or suspected infection. We don't need always a confirmed infection. Either a confirmed or suspected infection plus I need organ dysfunction. This organ dysfunction is assessed by using a tool. The tool is called as SOFA score. SOFA score. SOFA stands for Sequential Organ Failure Assessment Tool or Score. sequential organ failure assessment tool or score, plus acute rise in SOFA score by more than or equal to 2 points. Then we can diagnose a case as sepsis. So if you have suspected or confirmed infection, let us say that someone came to me with an abscess somewhere. That means there is a suspected or a confirmed infection. Now I calculate his SOFA score, and his SOFA score from the previous value has jumped by more than or equal to 2 points. Then organ failure is also confirmed. Then sepsis is confirmed. Conceptually, organ dysfunction which is happening because of dysregulated host response to infection. So to diagnose it, I need infection plus organ dysfunction. Organ dysfunction is quantified using the SOFA score. So this is what SOFA score looks like, the sequential organ failure assessment score or scale. So in that, what all organs are covered and what all parameters are assessed. The first one is respiratory system. For the respiratory system, the parameter that we are looking at is the PaO2 by FiO2 ratio. PaO2 by FiO2 ratio. Right? Will the respiratory system be affected in sepsis? Yes, the inflammatory cytokines that are produced in response to infection, they go and cause damage to the lungs, and we call that condition as ARDS. So sepsis can lead to acute respiratory distress syndrome. And for the ARDS, if you remember, the diagnostic criteria takes into account PaO2 by FiO2 ratio. So that is used for assessing the respiratory system. Then for the hematological system or coagulation system, we mainly look at the platelet count. Platelet count. And then for the liver, we look at the serum bilirubin to assess whether liver is affected by sepsis or not. For the CNS, of course, we are going to look at the GCS score, Glasgow Coma Scale score. And for the kidney function, we are looking at the creatinine, serum creatinine value and urine output. These are the two parameters used for the assessment of renal functions, right? Clear? So what all we are looking at? We are looking at respiratory system by looking at PaO2 by FiO2 ratio, coagulation by looking at platelet count, liver by looking at bilirubin, CNS by looking at GCS, and kidney functions by looking at urine output and creatinine. Now coming to the cardiovascular system. Cardiovascular system, how will I assess? What is the main function of cardiovascular system? Pump and deliver blood to tissues. If tissue perfusion is impaired, that means cardiovascular system is dysfunctional. So that we can assess by looking at the blood pressure or mean arterial pressure. Instead of defining it separately as systolic and diastolic BP, we will take the mean arterial pressure. Now from this table, what questions they will ask you in NEET PG and INICET? They will not ask you to calculate the SOFA score for a individual because it takes time, and in the exam they can't frame a question which takes 4 minutes or 5 minutes of time. So what they will ask you, what are the components of SOFA score, or which of the following is not a component of SOFA score, or which of the following organs are assessed inside SOFA score, or which of the following organs are not assessed inside SOFA score. So what you need to remember is we are assessing the respiratory system, coagulation, that is hematological, then liver, cardiovascular system, central nervous system, and renal system. What parameters are used for respiratory system? PaO2 by FiO2 ratio. For the coagulation or hematological system, platelet count. For liver, serum bilirubin. For CVS, mean arterial pressure. For CNS, GCS, and for the renal, serum creatinine and urine output. Now for a healthy individual, what is the SOFA score? For the healthy individual, the SOFA score will be 0 because we will have the normal PaO2 by FiO2 ratio, we will have normal platelet count, we will have normal serum bilirubin, we will have normal mean arterial pressure, we will have normal GCS which is 15, we will have normal creatinine and normal urine output. So we end up with 0. So let us say that there was a person who did not have any organ issue. Okay. And now he came with infection somewhere. Let us say he had an abscess, and then we calculate the SOFA score. Before this, he did not have kidney problem, he did not have heart problem, did not have brain problem, did not have liver problem. Now he has come, and then when I record, I notice that his creatinine is high. Maybe it falls in the range of 2 to 3.4 milligrams per deciliter, this place. So then I have to give 2 points for this kidney involvement, right? What the definition says? Acute rise in SOFA score by more than or equal to 2 points. His previous value would be 0 because he was healthy individual. Now it is increased by 2 points. So the criteria is satisfied. So I will call it as sepsis. But then again remember, what if patient already had organ dysfunction? What if he was on alcoholic and he had CLD? So in that case his bilirubin may be already high. So let us say his bilirubin was already 3. So he was already having a SOFA score of 2. So for a healthy individual, the SOFA score is always 0. But patients with pre-existing organ dysfunction may have higher SOFA score. Let us say this patient whose bilirubin was in the range of 3, it falls here, right? So let us say I am dealing with a patient with chronic liver disease, and because of CLD his bilirubin was high, so his already SOFA score was 2. Now how will I diagnose this patient as having sepsis? Let us say this case of chronic liver disease comes to me with fever, urinary dysuria, and maybe when I scan, I find that he has got pyelonephritis, kidney infection. Infection evidence is there from ultrasound and urine routine, and I check his SOFA score. Now I notice that his creatinine is increased. His previous creatinine was normal, only bilirubin was high. Now his creatinine is increased. Because of that, SOFA score has jumped from, now the SOFA score has come here, 4. So I get 4 points from this already existing 2 points. So SOFA is now changed from 2 to 6. What the definition said? Acute rise in SOFA score. Whatever is your previous value. If you already have organ dysfunction, you have some value. You have no organ dysfunction, you have 0. If it jumps by 2 points, here it jumped by 4 points, I can call it as sepsis. Healthy individual is usually 0. If it jumps by 2 points, I can call it as sepsis, right? So that is a basic definition of sepsis. Now comes another question. I understood sepsis, but then there comes a term called as septic shock. Zohaib, just give me 1 second. You are in class 11 and preparing for NEET. Zohaib, so this platform right now, what I'm teaching is for the NEET PG students. So I'm not the expert for the NEET UG, but the physics wala also has the NEET UG channel. If you go there, you will find the faculties for physics, chemistry, and biology and mathematics. They are the right people to guide you for your cracking the NEET UG and IIT. Rock Chetia, yes. We will be updating most of the lectures in the medicine subject in the couple of months. Okay, so now we have understood what is sepsis. Let us understand another important term called as septic shock. The moment I say shock, what comes to your mind? Hypotension, right? But then what is septic shock? Septic shock refers to suspected or confirmed infection which has resulted in shock. Suspected or confirmed infection which has resulted in shock. Now here, how will I define shock? The shock will be defined as need for vasopressors. What are vasopressors? Adrenaline, noradrenaline, which are used for increasing the blood pressure. Need for vasopressors to maintain mean arterial pressure. Maintain mean arterial pressure of more than or equal to 65 millimeters of mercury. What does that mean? Means this patient's BP is not being naturally maintained. I am giving inotropic agents to maintain the BP sufficient enough for the survival of organs. Then it is not normal, right? Plus serum lactate more than 2 millimoles per liter of blood. So increased serum lactate. So can anybody tell me why am I using serum lactate as a tool here? What is the relevance of having serum lactate included in the definition? So when these 3 things are there, you can call it a septic shock. A patient should have suspected or confirmed infection and his BP is not maintained by just fluids alone. We are requiring inotropes to maintain the BP. And when we look at his serum lactate levels, they are elevated. What does that indicate? The elevated lactate. So lactic acid is produced as a result of anaerobic metabolism. So if tissues are getting, all your cells are getting sufficient oxygen, then we burn the glucose to finally produce carbon dioxide and water. But if I am not giving sufficient oxygen to the tissues, then they go into anaerobic metabolism, and the byproduct of it is lactate. So if lactate levels in the blood is high, it indicates that tissues are forced to do anaerobic metabolism. That means tissues are not getting sufficient oxygen. When do they don't get sufficient oxygen? Either blood oxygen level is low, yeah, blood delivery to tissues is low, and in short that is what happens, right? There is tissue hypoperfusion. So it is an indirect measure of tissue hypoperfusion. So if you want me to write, I will just write down, this is suggestive of tissue hypoperfusion. Tissue hypoperfusion. Okay, now both these patients who are either having sepsis, infection with organ dysfunction, or having septic shock, infection with BP not maintained without inotropes, and lactate being high, suggestive of tissue hypoperfusion, both these patients are at very high risk of death, very high mortality rate, right? So let us learn why this sepsis happens and how are we going to manage these patients. So sepsis is what? It is a organ dysfunction because of dysregulated host response. So let us say someone got an infection. The infection triggers body to produce pro-inflammatory cytokines. Pro-inflammatory cytokines. So in your second year pathology, you study what are pro-inflammatory and what are anti-inflammatory cytokines. These pro-inflammatory cytokines, I'm just writing few examples that includes interleukin 1, interleukin 6, TNF alpha. These are all pro-inflammatory cytokines. Now these inflammatory cytokines are not restricted to the site where there is infection. I may be having an abscess on my forearm, right? So there is an infection here, there is an abscess, so there has to be an inflammation there. But inflammatory cytokines, if produced in large number, if produced in large quantity, they will start circulating in the blood and they will be presented to different organs. So these pro-inflammatory cytokines, if they are produced in excess, right, they can be produced in excess due to dysregulated. I don't want this to happen, but it happens sometimes. Dysregulated host response. If they are produced in excess because your host response was not appropriate for the level of infection, then this excess pro-inflammatory cytokines, they will go to different organs and cause the damage. So what they will do to the lungs? Once they go to the lungs, they cause inflammation of the alveoli, and that condition we call it as ARDS, acute respiratory distress syndrome. Alveoli get inflamed and the dead alveolar cells and the debris, everything collects in the alveoli. Alveoli get flooded with the debris and the pus cells. We will call it as ARDS. Similarly, these inflammatory cytokines can go to the cardiovascular system. So what they will do to the cardiovascular system? In the heart, these inflammatory cytokines can suppress the cardiac function. So they suppress myocardium. So the force of contraction of myocardium can come down. Second thing they do is they cause profound vasodilatation. And what will happen if I do vasodilatation? What will happen to the blood pressure? If I constrict the blood vessels, the BP increases. If I dilate, BP decreases. So this will result in hypotension and tissue hypoperfusion, right? This will cause hypotension and thus tissue hypoperfusion. This condition is what we have called as septic shock if I am not able to control the BP with fluids alone. Then these inflammatory cytokines will also go to liver and they will cause liver inflammation. We will call it as hepatitis. So hepatitis is not always because of hepatitis viruses. It can happen because of drugs. It can also happen because of sepsis. So what it will lead to? Once there is hepatitis, we will have increase in liver enzymes, that is AST and ALT. And also you will have increase in serum bilirubin. Serum bilirubin. So the sepsis, if the host immune response is dysregulated and too much of IL-1, IL-6, TNF alpha, these are produced, lungs will develop ARDS, liver will start failing, cardiovascular system starts failing, you end up with hypotension. Then these inflammatory cytokines also go to the central nervous system and they will cause inflammation of the central nervous system as well, and we will call it as encephalopathy or septic encephalopathy. What is encephalopathy? Involvement of the brain by these inflammatory cytokines. Encephalopathy. So when the brain gets inflamed, its function gets affected, and you may have decrease in the GCS value. Decrease in the GCS value. Similarly, these inflammatory cytokines will also go to the kidney. And when they go to kidney, they cause kidney inflammation and dysfunction of the kidney. We will call that condition as acute kidney injury or AKI. And one more complication that we saw plenty in COVID era, a lot of COVID patients also developed it. They also cause endothelial injury. This is particularly important. They cause endothelial injury. And remember, whenever there is endothelial injury, there is a propensity for developing clot. Do you remember something called as Virchow's triad? Virchow's triad. Virchow's triad was a triad which increases the risk of forming a clot, right? What are the components of this Virchow's triad? In Virchow's triad, we had endothelial injury as a component of this triad. Endothelial injury, hypercoagulability, and stasis or stasis. If blood stagnates in a place for a long time, increase the risk of clot. If blood has hypercoagulable conditions like protein C, protein S deficiency, there is a chance of developing clot. And if there is endothelial injury, there is a chance of developing clot. Now, why endothelial injury pushes you to develop clot, right? Let us try to understand that. Normally, in the subendothelial space, let us say this is a blood vessel that we are looking at, and the blue line is endothelium. This is the rest of the blood vessel wall. Underneath this endothelium, we have factors called as von Willebrand factor. Von Willebrand factor. And whenever there is some degree of endothelial injury, these von Willebrand factors get exposed. And von Willebrand factors have the receptors for platelets. So as soon as endothelial injury happens and von Willebrand factors get exposed, they will get the platelets attached to them. So it forms a platelet plug. This step in the coagulation cascade, if you remember from first MBBS and second MBBS, we call it as platelet adhesion, right? After that, these platelets send attractants for other platelets to come, like thrombexin A2, ADP. Other platelets come. When these platelets send ADP, thrombexin A2, they attract other platelets come and join. This step is called as platelet aggregation. Platelet aggregation. And when both the steps are completed, we have a fully formed platelet plug. Why did this happen? Because we had done endothelial injury and exposed the von Willebrand factor. Same thing can happen in sepsis. These inflammatory cytokines, they will go and cause endothelial injury. And once there is endothelial injury, there will be platelet plug formation. So if multiple areas there is endothelial injury, we will have multiple clots formed in the blood vessels. It's not like one cut, right? Different areas, different blood vessels, multiple clots. What will happen to the platelet count? Can anybody think and tell me? If I have extensive amount of blood clots all over the blood vessels, what will happen to the platelet count? So all the platelets get used up in forming these plugs, right? So what will happen to the platelet count then? Because most of the platelets are taken up in forming these platelet plugs, the circulating platelet count decreases, right? We will call it as thrombocytopenia. And this whole phenomenon where widespread intravascular clot formation happened because of the endothelial injury triggered by these pro-inflammatory cytokines, we will call it as disseminated intravascular coagulation or DIC. Disseminated intravascular coagulation or DIC. And this condition is also called as consumptive coagulopathy because the platelets, clotting factors are all used up for this process, right? So this can also result in thrombocytopenia because all the platelets are being used up for forming these platelet plugs. That's why if you remember when we were talking about the SOFA score, the coagulation system is assessed by looking at platelet count. If platelet count is going low, what does that indicate? probably you have widespread intravascular DIC happening and platelets are being used up. That means the coagulation system is also, this is an organ or it's a system which is failing. So that's why we will be giving some points based on the platelet count to decide whether there is sepsis or not, right? So who is the root cause here? Inflammation is a trigger. It is your own immune system which is causing all the organ dysfunction, right? So now we have understood the sepsis pathophysiology. Let us see how I can improve the survival of these patients. I don't want multiple organs to fail, because once multiple organs fail, we will lose the individual. So there are two things that we can do. One, manage all these complications that arise. BP dropping, get it normalized with fluids, inotropic agents. Kidney is not functional, start dialyzing so that the job of the kidney is done. Then encephalopathy, right? Minimize the inflammatory cytokines, that might improve. ARDS, we might have to put the patient on ventilator. So one is organ support. But if I want to minimize the organ injury, first thing is minimize the infection, right? More the bacteria present, more will be the inflammatory cytokine produced, more will be the organ dysfunction, right? So if you take care of the infection, then probably the amount of pro-inflammatory cytokines will decrease and organ dysfunction will also come down. Okay. So now if I have to manage a case of sepsis, we follow guidelines called as Surviving Sepsis Campaign. Surviving Sepsis Campaign guidelines. It came in 2021 and we are expecting an update next year. So whatever that was discussed in 2021 is valid today for exams, NEET PG as well as INACT as well as your prof exams. So in that Surviving Sepsis Campaign guidelines, the emphasis is given for the management in the first hour, because studies after studies have shown that every hour you delay in initiating the best treatment, the risk of death of the patient like exponentially goes on increasing. So if I'm just sitting in the hospital wasting 2 hours of time before I act for a patient with sepsis, I've already pushed him towards death. So that's why quick recognition is important and quick initiation of treatment is important. How do I recognize quick? Every patient of infection, like anyone who is hospitalized with fever or any infection in the hospital, keep in mind he may be having sepsis or he may develop sepsis during the hospital stay. So please assess their organ function regularly, right? Check their respiratory system, check their CVS, check their coagulation system, check their CNS. What parameters we need to check? We've already discussed, right? For the coagulation, we are looking at platelet. For liver, we are looking at bilirubin. For kidney, we are looking at urine output and creatinine. For the respiratory system, we are looking at PaO2 by FiO2 ratio. So check all these regularly. The moment you see that these so far points have jumped by 2 points, you know you have a patient with sepsis. Start acting immediately according to the Surviving Sepsis Campaign guidelines. So first thing that they recommend is measure serum lactate levels. Why? Because serum lactate levels are our window to understand whether there is tissue hypoperfusion is there or not, right? It is suggestive of increased serum lactate level is suggestive of increased serum lactate is suggestive of tissue hypoperfusion, is a pointer towards septic shock. It is suggestive of tissue hypoperfusion. It is a pointer towards septic shock. Then the next thing, after measuring the lactate, if it is more than 2 millimoles per liter, you have to keep serially monitoring. Serum lactate levels coming less than 2 millimoles per liter after initiation of treatment means it's a good sign. Okay. Second, you have to obtain blood cultures, because you have to treat infection and you need to know which organism is responsible for the infection. So you need to do blood cultures. Make sure that the blood cultures are preferably taken before administration of antibiotics. Preferably before antibiotics, because once you give antibiotics, the blood culture may not come positive. The organisms get suppressed and you may not be able to grow them in your culture media, and then you may not get to know which organism was responsible. So preferably before antibiotics. But if you feel that taking the culture is going to delay initiation of antibiotics, then go ahead with it. But taking the blood for cultures is a very simple procedure. It's not like doing lumbar puncture for CSF for meningitis. So there we say that don't waste your time for the CSF to be drawn and then start antibiotics. Give antibiotics in the first hour, no matter what. But in case of sepsis, drawing blood from vein is not a very big task, right? You can do it, staff nurses can do it, anybody in the hospital who is trained basically can do it. So quickly get it done and then start the antibiotics. And then we have to begin fluid resuscitation if patient is in hypotension. And then MCQ they will ask you is, if the patient is in hypotension, what fluid you will prefer and how much you will give. So there are 2 points to remember here. We have to use around 30 ml per kg, 30 ml per kg of patient body weight. Let us say if I am dealing with a 50 kg individual, 30 ml per kg into 50 is 1.5 liter, right? 30 ml per kg, that much fluid I need to give. During how much period of time and what fluid? 30 ml per kg of crystalloids. There are two kinds of fluids, as you know, crystalloids and colloids. Colloids contain large molecular weight substances like albumin. The crystalloids do not contain large molecular weight substances, they only contain water and simple electrolytes. So we are going to prefer crystalloids, 30 ml per kg of crystalloids to be given over first 3 hours. Over first 3 hours. After that, we can assess the response to the BP and all, and then we can increase or decrease the fluid depending on the hydration status of the patient. There are parameters which can be used to assess whether the fluids are adequate or not. For an undergraduate student, that is not required. But this is what they will ask as an MCQ. How much fluid is used for initial resuscitation? 30 ml per kg of crystalloids. And then crystalloids are also, there are different types of crystalloids. There's something called as balanced crystalloids and non-balanced crystalloids. Now, what do I mean by balanced crystalloids? The balanced crystalloids are close to isotonic with the serum or the blood, and they contain not just sodium and chloride, they contain additional substances which are found in the blood. The non-balanced crystalloids contain basic elements, that water, sodium, chloride, or maybe dextrose. So the DNS or normal saline that we use is non-balanced crystalloid. What comes as balanced crystalloids? Ringer lactate or isolite. These are the balanced crystalloids. So we should prefer balanced crystalloids over non-balanced. If, let us say, the balanced crystalloids are not available, then definitely go ahead with some fluid is better than nothing. But if you have, prefer using balanced crystalloids over non-balanced crystalloids. So this is an MCQ. How much to give, over how much time, and what is preferred fluid. Okay, just to understand it better, let us take an example, mathematical example. If I am dealing with a 50 kg individual who is now having suspected sepsis and his BP is low, how much fluid I should give? 50 kg individual, 50 kg into 30 ml, that becomes, so the resuscitable fluid volume should be done with 1.5 liter of fluid over 3 hours. So that should, then what should be the infusion rate? I'm giving 1.5 liter over 3 hours. So per hour, how much I should give? I should give around 500 ml per hour so that I can achieve infusion of 1.5 liters over next 3 hours, right? That is how we are deciding the initial fluid resuscitation. Okay, after the fluid resuscitation is sorted, or I have started the fluid, now I have to also think about the antibiotics. And when it comes to antibiotics, we are starting it before the culture report is available. Culture report will be available 48 to 72 hours later. I can't wait that much. I have to start antibiotics, so it is empirical. And when we are talking about empirical, I don't know which organism is responsible, so better is choose a broad spectrum antibiotic. Broad spectrum antibiotic, keeping in mind possible organisms. For example, let us say I got a patient with COPD and he is now respiratory infection. He has come with COPD exacerbation. I get the X-ray done, there is a pneumonia visible, and now he has sepsis. His kidney is gone for a toss, his BP is low, so SOFA score has jumped by 2 points, so he is in sepsis. The source of infection is lungs, but multiple other organs are getting affected, so that is classical sepsis. Now, because I know the source of infection is lungs, I know what are the possible organisms. The common infection that occurs in COPD patients is Streptococcus pneumoniae. Other than that, Klebsiella pneumophila, Pseudomonas if there was recent hospital exposure, So these are the common organisms. So I should have a fair idea about which are the common organisms likely to cause this infection. For example, again, if I talk about the urinary tract infection, let us say someone came with UTI and then ended up with sepsis. What are the common organisms you should think of? First thing that should come to your mind is E. coli. Apart from that, you can think of Klebsiella and other organisms. So if you have that picture in your mind, then you can choose a right antibiotic. If I'm thinking of a respiratory system infection, then what are the antibiotics that will be covering the Pseudomonas, the antibiotics that will be covering the Streptococcus pneumoniae, Klebsiella? I will choose such broad spectrum antibiotics. So there is no hard and fast rule saying that you should use only this antibiotic or this class of antibiotics. You should have applied your basic understanding of the microbiology, keep in mind the possible organisms, and based on that choose an antibiotic which has a broad spectrum coverage. Okay. Then we might have to use vasopressors if mean arterial pressure is less than 65 millimeters of mercury despite fluid resuscitation. Means I have given this much of fluid as per the standard protocol. I have given 30 ml per kg of fluid, but despite that the BP is still low. Then we have to consider vasopressors despite fluid resuscitation. Now in the NEET PG exam, they will ask you what is the vasopressor of choice. Means we have drugs like adrenaline, noradrenaline, dopamine, dobutamine. What is the vasopressor of choice? What should I use? Right? That's again an important MCQ point. So the vasopressor of choice, or you can say drug of choice as vasopressor for a patient with septic shock or hypotension which is not responding to fluid resuscitation, is going to be noradrenaline. Noradrenaline is the vasopressor of choice. Noradrenaline is the vasopressor of choice, right? So this is the basic management of sepsis. All of this should be done in the first hour of suspicion. Like patient came to me, I suspected a sepsis. In the next 1 hour, I should measure the lactate levels, I should obtain the blood culture, I should start the fluid resuscitation and administer the first dose of broad spectrum antibiotic. And if the patient BP is not responding to fluid resuscitation, I should start the vasopressors, right? This is the basics. Now, this is only trying to minimize the damage, but organs may already be affected. I also need organ support. So what organ support I can offer for these patients? If the patient has developed respiratory dysfunction, which is nothing but ARDS, then how do I manage it? ARDS management itself is a big topic. We have to mainly follow what is called as mechanical ventilation with ARDS specific settings. Means you should put the patient on ventilator, but in ventilator, patients with ARDS tend to progress faster or their lungs get more damaged if the ventilator settings are wrong. And it is also one of the reasons for many patients developing worsening of their chest x-rays after intubation if the duty doctor doesn't choose the right setting. So what is the right setting? There are so many parameters right now because we will be discussing ARDS in one more redirection series. The important one that I want you to remember is you should follow a low tidal volume setting. These patients alveoli are inflamed. They are very much fragile, very much vulnerable for the injury. So you give high tidal volume, that volume distance the alveoli causes more damage, more inflammation. More the inflammation, ARDS progresses much faster. So low tidal volume, high PEEP setting. When I say low tidal volume, we are giving a tidal volume of approximately 6 ml per kg. Okay, so let me ask you a question. What is normal tidal volume? I always get one standard answer, sir, 500 ml. Is that right? No, the tidal volume is not fixed. You can't say that a 100 kg or 150 kg individual will have, or 500 ml of inspiration is sufficient to oxygenate his blood and get oxygen to all the tissues. No, it's not fixed. The tidal volume varies according to your weight. There are other parameters like ethnicity, gender also influences. Roughly, you can say weight is the main determinant. So around 10 to 12 ml per kg is the normal tidal volume. So if I'm a 50 kg individual and you take the tidal volume on the lower end, that is 10 ml, then it is 500 ml. If you take 12 ml as the tidal volume, then it is 600. So we can say that a 50 kg individual is supposed to have a tidal volume of 500 to 600 ml. If I have a 100 kg individual, he may have a tidal volume of almost 1 liter to 1.2 liter. So normally when we put patient on ventilator for some other indication, let us say because of pneumonia, or let us say because of respiratory failure due to neuromuscular blocking agent or whatever, like for anesthesia cases, we are giving the patient on ventilator, then we will be using 10 to 12 ml per kg as tidal volume. That much volume is not tolerated by the already inflamed alveoli in patients with ARDS. So that's why we need to follow low tidal volume. Extremely important MCQ point, asked more than 10 times in the previous 7-8 years of the entrance exams. So I want you to remember. And we are also following along with that high PEEP, high positive and expiratory pressure. Okay. So right now don't bother about what is this high PEEP. Once we take up the ARDS, you will have a clear idea about the ventilator strategies. But for now, remember these points. If the patient has developed the renal dysfunction, then we will be following with fluid resuscitation. Of course, we have already discussed how much fluid we generally give. But if that is not helping the kidneys to start functioning back, then we might have to consider putting the patient on renal replacement therapy, which is also called as hemodialysis. Okay. Then hematological, if you're suspecting that the patient is likely to develop the DIC, is it preventable? Yes. So you may consider using heparin to prevent for two complications. One of them is developing DVT because the patient is hospitalized, and second, disseminated intravascular coagulation. Okay. CVS, patient can get into shock or hypotension. So you can consider using vasopressors. Vasopressors if there is hypotension. What is the vasopressor of choice? I have already told you the vasopressor of choice is going to be noradrenaline. Now all these are organ support. So basically how we manage sepsis is try to contain the infection by giving antibiotics, right? Try to maintain the BP sufficient by giving fluids, and if required use vasopressors so that the organs are receiving the sufficient amount of blood and oxygen and they continue to function, right? But then all this problem, the culprit is your own immune system. Can I suppress it? Can I suppress it? Can I afford to suppress it? Well, that's a gray zone that we are entering. Whether can I suppress the immune system by giving steroids? It's a gray zone that we are entering. So all the previous literature used to say that steroids do not have any benefit. But last few years, we have zeroed down that steroids have a role and benefit in management of sepsis, especially if the patient is in septic shock. If they are in shock, if I give steroids, one thing I achieve is suppress these inflammatory cytokines. So further suppression of the myocardium, vasodilatation that is happening because of these inflammatory cytokines comes down, the BP improves, right? Second, during stress, as such, we need high amount of cortisol. Now, in a patient with sepsis, studies have shown that adrenal response may not be appropriate, means the adrenal gland may not be able to produce as much cortisol as body needs. So, giving this extraneous or cortisol or steroid from outside helps to patch up for that adrenal gland's failure. So, studies have now shown that steroid use in a patient with septic shock reduces the mortality. That's why it is recommended now. So previously it was not recommended, but now it is recommended. So hydrocortisone, (200 milligrams) IV per day in divided doses is recommended for patients with septic shock. I am writing only because it's not recommended for routine use in all patients of sepsis, only those who are in shock. And who is a patient of septic shock? Suspected or confirmed infection with that patient with infection who is requiring vasopressor or inotropic support to maintain the mean arterial pressure of more than or equal to 65 millimeters of mercury, and his lactate levels are more than 2 millimoles per liter. Means BP is barely being maintained with the help of all these drugs. And despite that, your tissue perfusion is not good. That's why tissues are into anaerobic metabolism, and that's why your lactate is high. Such patients, there we will be using hydrocortisone only for patients with septic shock. For patients with septic shock, not for routine cases of sepsis who are not in shock, right? So that's about our sepsis. Now we will quickly recap what we have discussed and the key MCQ points, and then we will wind up today. What is sepsis? Sepsis definition is life-threatening organ dysfunction due to dysregulated host response to infection. A host is supposed to do inflammation which is proportionate to infection, but in many individuals we will have disproportionately high inflammatory cytokine production, which is disproportionately high in comparison to infection. The technical criteria for diagnosis of sepsis is any patient with confirmed or suspected infection where the SOFA score, sequential organ failure assessment score, increases from his baseline value. For a healthy individual, baseline value is 0. Patient with already existing kidney, liver disease and all, it may be high. Whatever is the baseline value, from there, if the SOFA score increases by more than or equal to 2 points, then we are going to call it as sepsis. Septic shock is what? Suspected or confirmed infection where the infection has caused shock and now the patient is requiring vasopressors to maintain the adequate blood pressure, which is defined as MAP of 65 millimeters of mercury, and the patient's lactate is high despite use of vasopressors and fluid resuscitation. Patient lactate is high, indicating that tissue hypoperfusion is there. These patients are called as shock, and these are the patients who will benefit from use of steroids. For all other cases where there is no shock, there is no role for steroids. Second MCQ region, the region from where MCQs will be asked is the components of SOFA score. So they will either ask which of the following organ assessment is not included in SOFA score, or they will ask which of the following is the parameter used for assessing the respiratory system involvement in sepsis by SOFA score, or which of the following parameter used for the cardiovascular. So you should remember what are the parameters used. For respiratory, PaO2 by FiO2 ratio, which is also the diagnostic criteria for ARDS. For coagulation, it is platelet count. I just also told you the platelet count is expected to be low in patients with sepsis because of the disseminated intravascular coagulation. Second, liver, we are using bilirubin. Cardiovascular, we are using MAP. For CNS, we are using GCS. And for renal, 2 parameters are there, creatinine and urine output. Okay. So now why all of this organ involvement happens? Because our immune system does disproportionately high production of pro-inflammatory cytokines, which are causing the inflammation of all these organs. So when I have to manage these patients, I have to do 2 things. One, reduce the infection. So I have to use antibiotics. I have to use broad spectrum antibiotics, right? Preferably before I give the first dose of antibiotics, I should draw the blood for the culture sensitivity, right? Second, in patients with shock, I can also suppress this inflammatory cytokine production by giving hydrocortisone. Apart from that, all these organ dysfunction require support, right? So to prevent the DIC, I might have to use heparin, also DVT prone, so I might have to use heparin. For ARDS, I might have to use the right strategy of the ventilator. Then for acute kidney injury, I might have to support them with the dialysis. And for the hypotension or septic shock, I might have to give fluid resuscitation and the vasopressor therapy, right? So that's what the points we have discussed here. Key take-home messages are the culture should be drawn before antibiotics. The initial resuscitation volume of fluid is 30 ml per kg. Preferred fluid is crystalloid, preferably balanced crystalloids. And this 30 ml per kg should be given over first 3 hours. Okay. Antibiotics should be broad spectrum, not narrow spectrum. And while choosing the antibiotics, keep in mind possible organism responsible for that particular infection, right? And we will consider vasopressors if the fluid resuscitation is not sufficient to maintain the MAP of more than 65 millimeters of mercury. And when we are using vasopressor, the preferred vasopressor is noradrenaline. Okay. And organ support we have already discussed. For ARDS, ventilator. For the renal support, we can do fluid resuscitation, and not helping, we can go for dialysis. For hematological, we have discussed about heparin, CVS, vasopressors if there is hypotension. And if the patient is in septic shock, we may consider using hydrocortisone. This is again an important MCQ point. What is the role of steroids in a patient with sepsis? If there is shock, we consider using the steroids. If there is no shock, currently steroids are not recommended, right? So that's it from me today on the sepsis. In the next class, we will continue taking up these important 5 or 10 marks university questions, from which NEET PG questions are also frequently asked. So we will cover the ARDS and other emergency topics in the coming week. That's it from me today. Signing off. I'll see you in the next class. Till then, study well. Good night.